and thank you so much for joining me for this video. Diabetes. In particular, I wanted to have a space to present and say all the things about diabetes that I never wanted to say. So if you'll join me for this presentation, and of course, if you enjoy it, feel free to leave a comment in the show notes, leave a comment on the video notes, and then definitely shoot me a message if you have further questions. So, all right, let's get going. All right, so let's talk about diabetes. I am Charlize Davis. Thank you so much for joining me for this presentation. And let's talk about diabetes, what it is, living with it, and how you can support yourself as well as the ones that you love that are living with it. So here's an outline of what we're going to cover. We're going to talk about some of the basics of diabetes. We're going to discuss how diabetes affects, in particular, people of color. I'm going to go over the important numbers and go over them in a way that I really like to think about them. And then we're going to talk about lifestyle, in particular lifestyle medicine in diabetes. So I am Charlize. Thank you so much for joining me. I'm an internal medicine physician, been in practice for 14 years. And in my practice, which reflects probably much of society, I only treat adults, but I do treat probably a third, maybe more of patients in my practice are dealing with some form of diabetes. And to be frank, knowing the numbers of diabetes, probably every patient in my practice is affected by diabetes either through a family, relative, friend, spouse, or they themselves are dealing with diabetes. I am also a member of the American College of Lifestyle Medicine, and I'm actively working on my certification. And during this presentation, we're going to discuss how lifestyle medicine is the perfect answer for diabetes. When we use the term diabetes, we're talking about really separate diseases. And when I'm talking with my own patients, I often wish we had a better way to describe the types of diabetes. The end result of all of these, of course, is going to be high blood sugars. It's going to be uncontrolled blood sugars, but the route that it gets there, the pathology is actually quite different. So type 1 diabetes should almost be called autoimmune diabetes. It's really a very different process than what happens in adult diabetics. Type 1 diabetics tend to be young. Their immune system has been dysregulated or overactive, and unfortunately their immune system attacks their glandular system, in particular pancreas. So the end result is that this autoimmune disease creates insulin deficiency by destroying the pancreas. The body will actually make antibodies against parts of the pancreas, and that's what results in the hyperglycemia or high blood sugars. Type 2 diabetes, and I do believe when most of us are saying diabetes, we're meaning type 2 diabetes. I feel a better term would be metabolic diabetes. And this is a very different process that takes time. It takes many years of elevated levels of glucose in the blood sugars that lead to overuse of the pancreas, overuse of the beta cells within the pancreas, which also leads to dysregulation of the liver, dysregulation of the stomach, poor response of insulin in the muscles and the fat, and along with several other metabolic factors on a very small molecular level. Whereas there will be stages in type 2 diabetes in which the blood sugars will actually be low. Then over time, and as the dysregulation occurs, the blood sugars will actually go up as the pancreas fails. And then eventually we get high sugars. And then depending on how severe that symptom gets, those high sugars will then create the metabolic effects of kicking in a mechanism within the kidneys to dump sugars, causing excessive urination, which will lead to excessive thirst. And then because of a starvation effect that happens because glucose isn't getting into the cells, weight loss. And in the end result, of course, is diabetes. Maturity onset diabetes, or MODY, is not discussed very often, and I suspect might actually be undiagnosed. And this is a rare form of diabetes, and it's actually genetic. This can actually present in later adolescence or early adulthood. These individuals may be responding to oral medications, but unfortunately they may go on to need insulin. So the three main types of known diabetic diseases I mentioned here. And I strongly suspect that as we develop research and as science progresses and as the later generations grow up and save the world, we'll probably discover that there's more than these three main types. But just for a side-by-side comparison, type 1 occurs in early childhood. It's really an autoimmune disease. So, and it can happen in kids of any age. And because of the rapid progression and because they are so sick, by the time the disease is diagnosed, the pancreas usually has been very, very damaged, and the parts of the pancreas that make insulin don't work. These individuals have to be on insulin. Type 2 diabetes, more of the metabolic, takes time. It takes many, many years of too many sugars going into the blood and a dysregulation between the liver and the pancreas, in which there's a period of time where the sugars may run low, then they run high. With this type of diabetes, we can sometimes use medications by mouth and use some of the injectable medications to try to get the pancreas and the liver to work better. At the end, if we don't get this fixed, at the later stages, insulin must be used. Type 1 and type 2 diabetes can both be insulin dependent. Type 1 diabetes, as far as a cure, this gets into medical research and pushing the envelope as far as where medicine can go. It can be cured by using things like a beta cell transplant, or can possibly using immunosuppressant drugs. But unfortunately, just for the everyday person, a type 1 diabetic cure doesn't quite exist yet on a day-to-day basis. And rarely there is some ways that it can be reversed. Type 2 diabetes can be reversed. Even in the very severe later stages, it is actually possible to reverse type 2 diabetes. MODY, or the maturity onset diabetes, is a genetic disorder which maybe could be treated with oral medications, but those individuals may go on to need insulin. And typically they may have other disorders other than the diabetes. And right now we don't know that that can be reversed. So there's sort of a side-by-side of what diabetes, and just as a reminder, now moving forward, the diabetes we're discussing is the type 2 diabetes that occurs in it. I had mentioned just a little bit ago that in diabetes, in adult onset type 2 diabetes, there's a failure of multiple layers, not just one. So this diagram shows you roughly the liver, the stomach, the pancreas, and just kind of points out that within the pancreas, which, that's probably a good conversation to have, just discussing the pancreas, because the pancreas does a lot of jobs, a lot more than just making insulin, but is a very small part of the pancreas that produces insulin, the beta cells. And it's these beta cells in type 2 diabetes that may eventually go on to fail. It's these beta cells that also get attacked in type 1 diabetes. So for anyone that's interested and wants to know what your risk of diabetes is, this is a handy dandy little tool. A lot of us physicians are familiar with MD Calc and use it quite a bit. You plug in some numbers and it gives you risk of various diseases. I tested this on myself, and I honestly think this is one that anyone can use. So if you want to scan that QR code to take you to the site where it's going to ask you your age, your height, your weight, ask you some of your past history. Really helpful if you're wanting to know what your risk of type 2 diabetes is if you are not diabetic already. So when I am looking at labs on individuals, when I'm looking at the numbers, the temptation, I think, for most patients is to want to know what their glucose is and then see it as diabetic, non-diabetic, and move on. And even for us physicians, I think that we want to look and see a number and say patient's not diabetic, patient is diabetic, and then move on. But in real life, and particularly in the type of diabetes that any of us can get, which is the metabolic diabetes, these numbers run a spectrum. And although we make clear-cut delineations that are based on evidence-based medicine that tells us that certain blood sugars set you up for this risk of disease and that risk, these run a spectrum. So knowing where your blood sugar is, which starting off with just some basic labs, just a blood sugar, which can be checked in a number of ways, by finger stick, and also just with a lab draw. And in general, someone who's under 100 is likely fine. However, anyone who's between 100 and 119, that doesn't sound so high when we consider the diabetic diagnosis to start at a blood sugar around 120. However, if you're at 100 to 119, I personally feel that this is the most important time ever to prevent disease, to turn this around. So it's in those individuals that I tend to put a lot of attention on. If we're seeing a blood sugar, in particular, if someone hasn't eaten, has not had anything to eat within a few hours, and the blood sugars may be 110 or 112, this is a loud warning sign that there is a problem, that the pancreas may not be doing all of its job, and there's probably some interventions that are needed. Many of my patients are so surprised when I bring this to their attention, and I actually want to discuss in depth this blood sugar of 110 and why that is. So an action that I would frequently recommend, several actions, is start looking at the weight. In particular, if weight is playing a fairly significant role in the blood sugars, how is it best to address it? Many individuals don't like to admit to it, and we're all human. I don't like to admit to it either, but how many carbohydrates are in the diet, and should they be restricted? And the universal answer will be, unfortunately, yes. If your body is showing that it's straining under the blood sugars, and quite frankly, even if it's not, the American diet is very carbohydrate rich, much more than our bodies actually need, much more sugar than our body actually wants to use or can use. But in particular, if you're starting to show signs of sugars running high, then this is a time to definitely cut out the sugars wherever you can. I say address barriers to physical activity. Particularly if you're not exercising, I don't like to tell people just to jump all in, go join a gym, go, flip a tire end over end, or, start crunching or anything like that. Let's just see where you are and see if there's a little bit more that we can do. Or if you're doing some, let's see if there's a little bit more that we can do. And definitely for these individuals, being aware of stress and what role this plays. And then the biggest thing of all for individuals who are having pre-diabetes, this life change I believe is the biggest, is that we need to start monitoring the blood sugar. So no longer can we remain in the blind and not be aware of where those blood sugars are. So for those individuals who may be finding out on an annual visit their blood sugar is high, I will now ask them that we start checking the blood sugars every 3 months. And quite frankly, it may be time to even start checking the blood sugars at home with a glucometer. For the next group with a blood sugar of 120 to 140 that are meeting the diagnosis of an early diabetes, and that A1C that correlates to that's roughly like 6.6 to 7.0, and it depends on the lab and their normal values. So if you have labs you've looked at, it kind of depends on that. But in those people that are early diabetic, and just as the pre-diabetics, I believe this is a very, very important stage, because even if your initial blood sugars are in this 120, 130 range, it does not necessarily mean that you need medication. It is definitely a good warning sign that it's time to address all those lifestyle factors that we mentioned for the pre-diabetics, and do them in earnest. And then also home monitoring with a glucometer is the next step. Now, for everyone that goes beyond this is where things get very serious, and there's always room for improvement. And for my patients that are in the A1C of 7 or over, this is where we want to have the kindest, gentlest, but most aggressive approach, because now we are in the diabetic ranges of an A1C of 7 or higher. We are now at a very real risk of having complications of the eyes, of the kidneys, and of the arteries, and the legs and the feet, and the arteries around the heart, or peripheral arteriopathies, or coronary artery disease. These individuals likely are going to be on medications, because once the blood sugars run this high, we pretty much have to do medications. But also, do we want to do things like enlist the help of an endocrinologist? Do we make sure that a diabetic educator is involved? When we're getting into blood sugars over the 180 and over the 200 range, because the consequences can be so devastating, now do we want to be using insulin? Do we want to have an advanced insulin regimen where there's insulin around the clock along with insulin with meals, which we call basal bolus? And then, of course, anyone who's over 240, and in particular, these people, we are getting concerned that now we're getting organ damage. Do we want to go ahead and treat this type 2 diabetic as if they are type 1, where they need to be managed completely with insulin and they need to have a CGM or continuous glucose monitor? So I know for patients living with diabetes or worried about their diabetic risk, they will see these pockets of numbers, but in my mind, it runs this whole continuum where really we're all at risk and we're all on this scale, every one of us. No one's free of us. Maybe some of us are fortunate enough that we're not sick with diabetes, but really no one's out of this. For people of color, and I can definitely speak to for diabetics in the Black community, there are additional risk consequences, further concerns. For African Americans, the rates of diabetes are so very high. Up to almost 20% of African Americans are dealing with diabetes. The risk of diabetes is 77% higher in African Americans. And for minority populations, African Americans, and I do believe for really any people of color, the risk of consequences to the eyes, to the kidneys, that's the retinopathy, is higher than for those that aren't of color. As I was preparing this talk, I actually asked this question as I was searching my databases that I review. Does racism cause diabetes? Does it make the disease worse? And interestingly enough, although I'm a practicing physician and I've got some pretty decent years of experience, and I am a woman of color, I'm a Black woman, as I was asking this question, I didn't know the answer. So I decided to do some research. And it turns out racism, the experience of racism, living through it, may bring on diabetes, may make it worse. It makes it harder to live with it. But in particular, the experience of racism and these sort of daily traumas that go with this can lead to coping mechanisms that are quite unhealthy, and one of those being overeating. And interestingly enough, even though I've worked with thousands of patients dealing with this, I had not really quantified or asked myself this question myself. And even though I personally lived through racism as a woman of color, and particularly a physician, that with the experience of racism, that psychological trauma possibly create a setting of diabetes with chronic stress in the body, and could it make it worse? I came across a really interesting idea, and one that I had known and I'd heard of in my personal life and seen even in my own family, of the superwoman myth. And this myth is in particular for Black women who, from ancestral ties, ancestral trauma, societal, cultural, many factors, Black women are often taught that they are naturally stronger than other women just by the fact that they are Black women. And this sort of thinking leads to being overcommitted, being in a caretaker role far too many times, taking on the burdens of others to the expense of that woman. And this superwoman myth, turns out, can strongly relate to particularly Black women becoming diabetic much more often than their counterparts. So now that we've covered the basics of diabetics, and you've heard the basics from a practicing internist that just even an hour ago was treating a diabetic patient, I am so excited that I have had the space to study lifestyle medicine, and I have started in earnest really learning these really important principles that can apply to every aspect of our life. Lifestyle medicine is quickly picking up speed, and it's somewhat similar to some other specialties such as functional medicine and integrative medicine. In the American Lifestyle College of Medicine, there are 6 main pillars that are focused on, which are activity, nutrition, sleep, health, stress reduction, social connection, and reducing risky substances. And I fell in love with this concept when I began to realize very quickly that these 6 pillars could be applied to any diagnosis and could really help to alleviate almost any diagnosis. But in particular, how can we use these 6 pillars with diabetes? So, to me, this is where medicine gets fun. I'm so happy I'm studying this because beyond the really scary statistics of diabetes, how can we use the fact that if we become diabetic or we have a risk of diabetes, or we have a diabetic husband or diabetic wife or diabetic child, how do we use that to live better for all of us? So, with these 6 pillars, here are some of my ideas of how you can support the diabetics in your life, how you can support yourself with diabetes, how you can apply this concept in so many ways. So, here we go. So, activity, staying active. If you want to exercise, if you want to get out, do something or work with a trainer, perfect if that's for you. But for a lot of my patients, particularly women who are getting older, who don't feel comfortable maybe going to a gym or haven't felt comfortable doing anything, what does healthy movement look like? Well, it can look like a lot of things. My favorite, walking. And everyone that's ever worked with me knows it's the standard Dr. Davis lunch hour is taking her walk. I am a firm believer in my lunchtime walk. All my friends know this. Everywhere I've ever worked, that once lunch hits, if I have to make a choice between the walk and lunch and just for my own personal relief, I'm getting those steps in. So you can do walking, yoga, Zumba, hiking, but my advice that I give to my patients is just make it enjoyable. Whatever you're going to do, let's just make it something that you will like to do so that you'll keep doing it and play around. Maybe find a new hobby. Don't at all restrict yourself. I know a lot of people like to set goals with exercise, and I'm cool with that, but what I usually ask for is 150 minutes a week, which means if you get in 30 minutes during the work week, 5 days, boom, you got it. If you get in a little bit on a Monday or Tuesday, get in most of the week, you got it. The next pillar is nutrition, which is fairly all-encompassing and probably one of the most difficult as far as cleaning up the lifestyle. Diabetics have to be particularly mindful about what they're eating, what's going to be in their diet, will be in their diet in the future. And I know for us physicians, when we're working with our patients in the clinic, it's so hard to know how to advise people because when we're talking food, we're talking culture, we're talking about one of the most important aspects of your life. And for many folks, they're going to hear the message of all the foods that they can't have. My quick and dirty advice is, as you're working with your nutrition and you get established with a nutritionist that you trust and can get advice from, the easiest advice I can give is if there's a food that has a label, read the label and know it. And preferably if we can start replacing foods with labels with fresh, organic produce that doesn't have a label, it's probably a better bet. That's my quick and dirty advice. It's a much more complicated than that, but for the sake of this video, I think that's the safest. We often don't realize that sleep is actually very important for many things, not just for rest in the brain. If we don't get adequate sleep, especially for diabetics, the stress hormones produced by the adrenal glands will go into overdrive, and it'll make controlling the diabetes extremely difficult. So the role that sleep plays as far as managing diabetes is much more important than a lot of us ever discuss. And likely in the clinic, we really don't ever discuss this at all. Stress plays an important role in the management of diabetes, and unfortunately, undergoing large amounts of stress in life, such as a loss or major life change, can actually increase your risk of developing diabetes, and there are plenty of studies that actually show that. What I will often touch upon with my own patients, and this can be difficult to touch upon initially with diagnosis because there's so much information to review, especially just to keep the body safe and healthy, is addressing stress But definitely once the care plan is in place and we know what's going to be happening with medications and with treatment, and we've got the other things in place like nutrition, making sure to control the stress. This is a perfect time in life, really any time in your life where you've undergone a major change, particularly an illness, that if you don't have a meditation practice to actually start it, there's so many benefits, clinical benefits, to it rolling in something like a meditation practice, even at the onset of becoming diabetic. Of course, I have resources at my website, healingartshealthandwellness.com, if you are new to meditation or wonder if it's something that you should be doing. The Healing Art of Reiki, which I am a Reiki master, and I am a firm believer, offers so many benefits for those that are undergoing life changes, and definitely can help in coping with diabetes, helping you to learn to engage with your body. So many benefits. So again, check out my website if you want to know more about Reiki. It could definitely be part of your care plan if you are diabetic. I like to say to my patients that you should not try to do diabetes alone. It's not a solo disease. With the numbers that we discussed previously, we understand that diabetes absolutely is a community disease. So if you are living in a household with friends and family, unfortunately, you likely aren't the only diabetic. And in your social circles, in your friends, your community, your place of worship, you are not the only diabetic. So I encourage people to share their diagnosis, and you can use the diagnosis of diabetes to help you connect with others. And maybe something even positive can come from it, like a group where you share healthy recipes, or a group in which maybe you decide to get some healthy movement together, take your late evening walks together for safety. But it doesn't have to be anything that's isolating. I also tell my diabetic patients that because you're not likely the only diabetic in your house, as you're coping with this disease, it should be a family discussion. I have learned just with inquiring in my own practice, trying to find ways to help people beyond just the prescriptions, that oftentimes in multi-generational houses is a multi-generational disease. So rather than sort of submit to, this is our fate, it could be a point of healing in which you learn to go beyond it and learn as a family healthier choices you can all make together. And finally, in those lifestyle diseases, reducing risky substances. In lifestyle medicine, this can apply to anything, but of course for diabetes, the risky substance is going to be sugar. And keeping a positive note to it, the way to see it is that if sugar has played an important role in your life, or you're concerned that maybe you have a sugar addiction, maybe it's time to start to deal with that. Deal with it as an addiction. Ask for help. Ask your doctor what can be done if you find that sugary substances have played an overly important part in your life. So thank you so much for joining me for that video. I hope that it was helpful. And of course, if you did find this helpful, definitely share it with your friends or family. Share as much as you like. I appreciate your time so much. I discussed in there stress reduction as a part of lifestyle medicine. And I wanted to mention that in addition to a 21-day meditation challenge that I have available through Healing Arts Health and Wellness, I also have a book that's available on Kindle, the 21-day meditation journey, which is really handy. This book, it's got some places you can even journal, and it'll take you through 21 days of establishing a meditation habit with some simple, quick, easy to go to meditations that don't actually take much of anything. Maybe just pen, and you can use your book as a journal. It is available as an ebook as well. Thank you so much for joining me. Sign up for my newsletter if you want more. And until next time, it's so nice to connect with you. Thanks. Bye-bye.